Okay. Hello. Good evening, everybody. I am Dr. Pooja Sharma. I am the lead mentor for the MRCOG Part 3 course for Med Exam Expert. On the behalf of the whole team, I welcome you all to today's session. It's a webinar on two topics dealing with young adults. I'll be taking a station on that, followed by my co-mentor, my colleague, Dr. Mohamed Hassam Mahmoud. I think many of you know him from your part 2 preparations. He'll be talking about breaking bad news. We also have candidates who are appearing for the EBCOG part 2 exam, which is similar to the MRCOG part 3. And you all know that the part 3 exam is a talking exam, a speaking exam. So during the course of our discussions, we try to improve our communication skills and learn how to talk in the exam and score the maximum marks. So the part 3 exam is going to happen in November. And as you all know, we already have started the long comprehensive extended course, which is ongoing, and it's started with the first session, which happened 1 week back. And the comprehensive extended course is it's about slow, sustained preparation, in which we take separate sessions on each module. So it gives the candidates or the students time to prepare each module separately in detail before they appear for the session. And so that's why it's more and more comprehensive, and it goes over a period of around 2.5 to 3 months time. Later on, we will be starting our intensive courses, which will be shorter, 1.5 months courses, which will be intensive means, of course, there will be more portions will be covered in a shorter duration as compared to this comprehensive extended course. The two topics we are discussing now are very important, and they are part of some difficult topics which we encounter in the part 3 exam. You will be pleased to know that we have 2 lecture-based sessions in each course, which are on the difficult topic discussion. And the difficult topics will be things, the 2 topics in front of you, plus sexual assault, complaints procedure, angry patient, complications of surgery, how to deal with the station when you don't know anything about it, then labor ward prioritization, the gynae list prioritization. So these are the topics, bullying. These are the topics which are, unless you have prepared well for them, it's very difficult to do those stations in the exam. So we try to put emphasis on these kind of stations to give students more and more practice. So today we will start with the station and then go on to discuss the various domains now in that station, followed by a discussion about dealing with young adults. That will be my topic, and later on Dr. Hassam will be doing a station on breaking bad news. So we have 2 stations today. So one gynae case for me, and I think it's an obstetric case Dr. Hassam is presenting. Before that, let's see. So we have a lot of participants today. Who would like to present the station? You can write on the chat. It's okay. Even if you are new for preparation, it's fine. It's a practice one. Any volunteer for presenting the station? Who's Okay. Jeet,
Yes, yes, Dr. Pooja.
can you be louder? I can't
Yeah,
hear.
I can try.
Okay. Hi, Jeet. Can you introduce yourself?
Hi. Yeah, I'm preparing. I'm Jeet. I'm preparing for MRCOG Part 3. I didn't get seat last time, as well as EBCOG
Okay.
Part 2.
Okay, great. Great to see you, to hear you here. I know it's unfortunate that many of the students and many of the candidates could not get a chance to participate in the exam because of the pandemic since last year. And this has added to the stress of the exam. But hopefully, now onwards, most of you should be able to give the exam, and many of you should be able to give it in the November session. So, Jeet, the the pattern will
Yeah.
be same as the MRCOG Part 3. So, there is a 2 minutes reading time, and then a
Mm-hmm.
10 minutes session time, and I will be putting the timer on. All the
Mm-hmm.
other students who are here, all the other colleagues who are here, uh, all you should also use those 2 minutes to write down the important points as you would do in the exam. So you should have your pen and papers ready. And later on, all of you should make points when Jeet is presenting. Uh, Try to make note of the positive points in a presentation and the negatives if they are, so that later when we analyze and discuss, you can see your own thoughts about what you analyze. Because uh, here, whenever a course is happening, or when you're listening to another candidate or participant presenting a station, it's very imperative for you to do an active listening. Active listening means you should analyze what points you would like to add in that particular history taking or in the examination, and what things you would add when you are explaining the process to the patient. So all these things you should be making a note of, each one of you. That will help you to gain the maximum out of this station. So Jeet, this is a negotiation station, and the patient is not very easy. I
Mm-hmm.
will give you 2 minutes to read the station, carefully think what aspects of the problem you would like to discuss.
Mm-hmm.
Okay. Okay, your time starts now. Okay, 10 minutes. Jeet.
Okay. Hi, I'm Dr. Kaur, one of the doctor in the gynae clinic. Are you Miss Dinah Mattel and you're 16 years old?
Yes, doctor, I'm Diane.
Okay. So how shall I address you?
No, you can call me Diane, doctor.
Okay, that's lovely. How are you doing, Diane?
I'm okay, doctor.
As I can see, Diane, from your GP letter that you have certain concerns about the labia. And can you tell me in detail about I mean, what are your concerns? And is there any other thing also that you want to share with me today?
Yeah, actually, doctor, I like biology and I've been studying my body parts. So 1 year back, I noticed that the labia, as you call it, my labia is very abnormal. It's very big. Then, I went to the internet and saw the pictures, and I think it's really, really abnormal, and I'm very embarrassed. And because of that, I don't go for swimming, and I think if I tell my friends, they would make fun of me. I did tell my mother, but my mother doesn't know, has not seen it, but she's also very concerned about it, and that's why I went to the GP.
Okay. Okay. Yeah, I do understand your concern, and definitely I'm here to help you, Dan. But before we proceed for this, can I ask you a couple of questions to know better about you, and then we can discuss it further, and we can make a good management plan for you. What do you think?
Yeah, sure, doctor.
Okay. So, can you tell me about your general health? Otherwise, I mean, how are you? You're fit and well? Any other medical problem you have?
Walking and
No, I'm
Okay.
okay.
And about your periods?
My
Okay.
Please
And
mute your mics, everybody. Please mute your mics. Please mute your
okay.
mics. Okay. Sorry.
Okay. Yeah.
Yeah, carry on.
So, about your like, when did you have your last periods?
So my periods are all regular, doctor. There's no problem. My last period was 10 days back.
Okay. So, can I ask you a couple of personal questions, if you don't mind? It's part of my job.
Of course, doctor, no problem.
Okay. Okay. Are you? I mean, do you have any partner or?
No, I'm not. I never had sex, doctor.
Okay. So okay, then it's fine. And do you? Okay, I think there is nothing to ask actually. Nothing much to ask. Okay. So Diane, um, any um, any operations that you have before?
No.
Okay. And how's school going on? You are in which grade?
I'm in the year 11, doctor. School is okay. I've been doing very well. Uh,
Okay.
no problems. But now I don't go for much for sports because I'm worried about this thing. I think
Oh,
doctor, I need surgery.
okay. Yeah. So Diane, how I mean in the present.
Hello, I lost you, Jeet.
Yeah, it got mute.
Yeah,
Okay.
it's okay. Carry on,
So,
carry on.
Diane, how would you like if I examine you in the presence of a chaperone? Would you mind? Your mother can
No,
also accompany if you wish.
no, I don't need my mother to come in. You can see, you can check, doctor.
Okay.
And I
Okay,
think
thank
you will also agree with me. It's very abnormal.
you. Sure, sure. I'll definitely look at it and tell you the clearer picture. Okay. So, Diane, I've examined you, and you know what? I will draw a diagram for you, and I'll explain you here that you see, everybody has a different structure and different body structure, in fact. And what I found is that you see, this is the vaginal opening, and it is surrounding here the labia. As you already said, you have read about it. So the outer lips, they are thicker than the inner ones. So according to me, when I have examined you, I found that they are like as per your body texture and body contour, I find it perfectly fine. And I don't find that there is any issue with that. So, rest assured. But still, if you want, we do have certain options for you. If you wish, I can discuss it with you.
I think, doctor, you may think it is normal, but when I see the pictures on the internet, I think definitely it's not normal, and this makes me stand out. And I would, if I think I have read about the surgery. I think the surgery can sort it out. You can just do a surgery from down below, and then I think that would help me.
Okay. Regarding the surgery, I would like to tell you that even if we do a surgery, what it will do, there are some plastic surgeons will be involved, and cosmetic surgeons, sorry, they'll be involved, and they will decide about it. So what we can, and in that surgery, they do they cut the labia and then they suture it. But if we cut after the surgery, there can be certain complication in the form of, there can be scarring of the labia, and there can be a very small risk of having infection also, and sometimes internal bleeding may happen that can further, uh, which can further change the texture of the labia. So looking at these complications, we have to really be sure before sending you for the operation. But may I ask your height to weight ratio? I'm sorry, I didn't ask it before.
It's 25.
Okay. So before going to that, I wish that we will have a joint meeting with the consultant, and we can discuss the issues further there with the consultant, and we all can decide it for it. And
But
we do have
it's possible to do the surgery, doctor, isn't it?
See, it is not required at this stage, because the labia and the entire down below area, that is normal for your age and stage, and there is surgery is not at all required, but it is only required in very few cases where it is generally the something is abnormal down there. But for you, surgery is not required, and all the operations do have their own risks. So that is why I'm explaining you about the risk of the operation also. And before going for surgery, if you are at the end, it is your decision. But before going for that surgery, we need to check for your ma'am. Actually, I went out of track. I think I'm going out of track. I need to assess her by the Fraser
The
guideline.
station is still going on. You have to just complete
Okay.
it.
Yeah. So first we have to make I would have to book a joint meeting with the consultant, and then in UK, what happens, we do have certain guidelines if you are below 16 years or 16 years. So we first assess the capability about the about the any decision making of regarding the surgery. And in your condition, it is not required, Diane. And I can book your appointment with a good counselor also, who can tell you more about it and who can help you in this situation.
I think the GP also said the same thing to me, doctor, but I don't think you're understanding my problem, because I cannot have a boyfriend because I think I'm abnormal, and everybody says that you are normal, you're normal, but I think it's abnormal. So I don't know who can help me with it.
Yeah, that is what I'm telling you, that right now I can support you with the counselor. We do have very good counselor who can help you in this, and we have certain therapies also in which we can you can really come out of this situation with what you are thinking about. You can feel better, and it can change your
Okay,
perception
time's
for
up.
the appearance.
Time's up.
Okay.
Okay, Jeet. How did it go?
It went very bad, ma'am. I know. I never saw this station before, and it was quite a new thing. Like, what to say? I mean, I don't know how to convince her. Where
This
to
station
go?
I do this station every time, and actually, even if you know this station, it is difficult. So I agree with you. It is difficult. It's
I
a
didn't know how to
purely
go.
yeah, it's a purely communication station. There's nothing much applied knowledge or anything in this. It's mostly how you negotiate with the patient and try to get your point across, and it is difficult to do. And I do it every time in a free webinar because this kind of difficult stations, if we start with, it's the easier stations, you know, they are easier to do. No problem. It's good you volunteered. I think to volunteer in a big gathering is itself a great achievement. I think so, and it will improve your confidence. So let's hear, before I talk about it. Let's hear from few people who were wanting to present and see what they say before I give you feedback. And please, all of you, including you, Jeet, take all feedback positively, even if it is a critical feedback, and if somebody tells you about the negatives, it's for your own good. So I think everybody, I've had people in previous courses and during these discussions who feel bad sometimes. I know, you know, it's bad to hear some kind of feedback sometime, but I think all of us, it's for learning, you know. The feedback given to the person who's presenting also is meant for other people. So I think it's a great, you know, it's quite brave for anybody to, you know, 40 people, 45 people there, and oh, there are 60 people here in the room right now, and to present in front of so many people, it's a great achievement in itself. Thank you, Jeet, and I'll come back to you. Let me go to
Thank you, ma'am. But I would like if you were, I would love if you will also give me feedback.
I will give the feedback, of course. I'll have the final word. Don't worry.
Okay. Thank you.
Okay. Yeah. Okay. Mona, are you there?
Yes. Hi, how are you, Pooja?
Mona. I'm good. Introduce yourself, please, because you wanted to present, but I just went by the.
No problem. My name is Mona Azmi. I'm Egyptian working in UAE. And I just passed EBCOG part 1 in May, and I'm preparing for November, inshallah.
Great. Welcome to this session. And so how would you, you know, what points would you add in Jeet's presentation? What were the positives in her presentation, and what would you like to add?
First, for Jeet, there is very good point that she started very good introduction with the patient, and she asked her about the name and the age, and she get the background, the idea about the session itself, and she went through the history. She missed this small few points in the history, but otherwise it was okay. And her communication with the patient was very, very good. She was cooperative, and she empathetic, and she didn't show to the patient that she's having some odd thing in her mind. She was very good in cooperation with the patient. So that's a good point related to the Jeet interaction. But I feel from the history she missed some few points, like about she should be asked about her mental health, about if she's supported at home or no, if there is any mental problem for her or for any of her family, and regarding to the drug allergy as a safety point, and she asked about if she had a partner or any sexual relationship, but she said no, but she didn't go in the deep on that. She need to ask why till now you didn't have any relationships, to make sure about if this is the main issue only, that her appearance, or there is anything else. And I think she needs to ask also about if she's feeling any other parts in her body to look abnormal or no. And if she had any treatment before or counseling before with any psychiatric problem before or no. She offered her a counselor, and that's good point. This patient mostly she's having the problem in her mind that her self appearance doesn't look good, so she needs to be in need psychological evaluation before we'll proceed for any surgery, because she doesn't need the surgery. And the second thing, maybe I will offer her support group from the same problem that she's having. So, and it was managed by support, and she needs more counseling more than the surgery. And we can just inform her that the surgery is a last resolution, because she doesn't have any problem to be resolved by the surgery other than the complication that Jit explained to her already.
Okay, good. I think quite a few important points. So that's thank you, Mona. And then I will go to one more person, and that's Salma. Salma,
Hello.
are you there?
Yes.
Hello, Salma.
Hi.
Welcome.
Thank you.
Can you introduce yourself to us?
Yes, I'm Salma. I'm preparing for, hopefully, if I'll get chance in November.
Okay, great.
Yeah.
Welcome. And what other points? I think Jeet did a good presentation, considering it was a difficult station, and Mona added some few points. Anything else you would like to tell, or any point you would like to add?
Yeah, only one thing that, even though she doesn't know, but she was very confident that she continue this session. This is good point. And also she's brave that she attend this to present the case. I appreciate. And yes, most of the things she mentioned, but what she missed, I can add, just to, and also the other person, she also mentioned most of the things. So only that which one she didn't explain, this one is that to the swelling, the large labia, is there any tenderness or any pain? And she has any vaginal discharge or unusual discharge down below. Okay, and
Okay.
and also sexual, already she mentioned that to ask deeply that why she didn't do sex till now, then maybe she will be tell more about that. Yeah. And any sexually transmitted infection before, even though she didn't do the sex, but we don't know, maybe superficial or any other sex she has done. So any sexually transmitted infection, and what is her relation with she has any friend in the school, or is the relationship with them, and her normal behavior, everything is normal or not with the family and with the in the school also, that normally she is acting or not, any that means abnormal behavior, if she's mentally upset or anything. So then so to exclude her mental status, and as she's asking for the for surgical management, so to explain to her everything, and to that that it is not suitable for her, already she mentioned, but the psychosexual counseling is most important for her. That so, and to ask her also that she has any idea that why it is what could be, what is her opinion that what it could be. That it why it is large.
Hello.
Good.
Then she will explain that what could be DD. That means.
Okay, I think we lost her. Somebody else was speaking.
Yes, hello. I'm Homa. I'm preparing for the November exam. I just have one question.
Yeah.
Well, in this scenario, ma'am, in this scenario, the examination findings were already given.
Yes.
So, do we again have to say that I'm going to examine you? Because if the finding.
Yeah, so you can go either ways. You can say that I would like to examine you. Maybe the examination findings are from the GP, you don't know, or you can say that from the examination it seems the labia looks normal. You can go either way. It both should be okay. It's
Because
fine.
you see, because sometimes we are told that if the examination findings are already given, you don't have to say that I'm going to examine you
Yeah, so
again because it's like
so even if you
undermining.
say nobody. Sorry, what did you say in the end?
I said that if the findings are already given, and if you
Yeah.
try to examine her again, then probably you are undermining your colleague, or unless the examination
But you don't know who has examined, correct?
has
You
been
don't know who
done
has
long
examined.
ago, only examine her and say, I'm going to see what is this. Right.
No,
Yes,
but you.
because the examination, it just says that on examination everything is normal.
Yeah, so we don't know who has examined.
So
Maybe it's a GP examination. So you
so
even
to
if you say
examine
that
her, or we can just say that gathered from your notes that.
You can say either. I can go either way. You can say that I would like to examine you because she is
Yes.
again and again. Can you hear me?
Yes, I can.
Okay. So
Yes,
because
I
she's
can
going
hear
again
you.
and again that. Okay, I'm carrying on. So because she's going again and again that it is abnormal. So even if you say that I would like to examine you again, though in your examination findings it's mentioned that it is normal, but it might be a GP examination. It's not mentioned in the question. So even if you say that I'm going to examine you, it's not undermining your colleague because you don't know who has examined her, or if it is specifically given that you have examined her and then you find that the examination is normal, then it's okay. But then if you say that I would like to examine you in the presence of chaperone, it doesn't undermine your colleague or anything because she has come to you, she's continuously complaining that it is abnormal. So if you have to reassure her that it is normal, and if you say I want to examine you, there's nothing wrong in that.
Okay. Thank you very much.
Dr. Pooja,
ma'am,
sorry, I didn't complete that one. That another thing I want to say.
Because your voice we could not hear. Yeah, please complete.
Sorry. This one also I want to say also examination that if it is given in the question, so no need to explain that for examination because it is already given. So we can explain to her that it is normal, as we can see that it is normal. This is one thing. Another thing.
As far as I'm concerned, even if you say that it is, I would like to examine you, it's fine. If you can justify it either way. So in this exam, there is nothing like 100%. You can justify. If you say that okay, examination findings are normal, and then you are doing the station without trying to examine her again, also okay. But if G says I would like to examine you because the patient is going on and on, it's normal, is also okay.
Because here they don't like to examine repeatedly, so that's why I'm just.
That's fine, but you don't know when she was examined, correct? You don't know when she was examined, whether it's a GP examination. It's not mentioned.
Yeah, actually that was not
Another
mentioned. That
thing,
is why I told.
I asked, I'll agree. I would not take any point from you for saying that I would like to examine you under presence of chaperone when the patient is insisting that everything is normal, and you have to now reassure her, correct? So it's based. So you have to give. Even if you say that okay, the examination looks okay, also is fine because it's given in the question. So you can take it either way, and both ways will be okay.
Yeah, and that 16 years old, so she can give consent if she can understand everything, okay, and for the treatment purpose, she's not minor, I think, for the treatment. But for contraception or anything, that one need that more than 18 years. For
no. What are you saying? Sorry, you said for contraception you need more than 18 years.
No. For contraception, I think that means adult. We can say the adult, it will be more than 18. Okay, 18 or above 18 for adult. But for 16, they can give for the treatment, they can give consent if she can understand any mental disability or any there is no problem with the mental status. Okay.
No, but
She can give
what
consent.
are you saying? No, that's fine. But what are you saying about contraception? That she cannot
No,
give consent for contraception?
No, contraception also, this is another
Yes.
treatment. No, this is slip of tongue. Contraception, yes, contraception
yes,
she
exactly.
can give, yeah. But for the, I'm telling that major will be major, it will be 18. That means it is adult. But 16 they can
Okay.
give consent. Yeah.
If they
Thank you very
understand
much.
the thing. Okay.
Thank you.
Okay,
Ma'am,
let's go back. Yeah,
ma'am,
who's this?
Monica, ma'am. I want to
Yeah,
add one
Monica,
thing,
yes.
ma'am.
Yes.
I think she is not up to the age, ma'am. After 18 only, this surgery of the genitals will be can be done, ma'am. She
Okay.
is not eligible for that surgery, ma'am. We have to tell her in presence of a consultant and with a psychosexual assessment, and after assessment we have to tell her she can wait for up till 18 years. Then if she, even if she feels that, she can go to the plastic surgeon and have an opinion
Okay.
and this thing, ma'am. That's what I want to add, ma'am. Thank you, ma'am.
Okay.
Thank you, ma'am. Nothing else, ma'am.
Okay. So now let me get back into the discussion and let's see what Jeet said and what we can add on to what she did. Now, for any station, be A, B, or C, we should follow a template for history. Only if you follow a template, you will be able to complete your history taking and not miss the point. Of course, the history taking changes from station to station depending on what the case is, but there is a basic template which works for everything. And the first thing I say, which everybody initially, when they're in initial stages of preparation and in the beginning, misses the history of the presenting illness. We are very, very anxious to ask about the medical history, the surgical history, the drug allergies, the social history. The first thing we have to ask is the history of the presenting complaint. The presenting complaint in this case is that she thinks her labia is abnormal. So first you have to ask everything about her presenting complaint. So first thing is, okay, what is the complaint? What is the main concern? So she says it's big, it's abnormal. Then you have to, and I think somebody added that how did you know? Like how, like so she says I look at my body parts and I think, so you have to ask specifically, it's something which you found out or anybody told you that your labia is abnormal. You're always, because this kind of station you have to gather sensitive information, and so we have to ask specific questions regarding it. Then of course you have to ask if she's having any physical problem, which one of the friends added on. She says I don't go swimming, so you have to ask whether if she's using tampons, whether she has problem wearing tight fitting clothes. Is there any physical problem she has because of this large labia? One is that she's thinking it is abnormal, it doesn't look normal. That's one issue. Second issue is whether she has any physical manifestation of her concerns, that whether tampons or wearing clothes or anything which may be a actual problem, the big labia which is interfering in her day-to-day activity. Because he says I stopped swimming. So you have to gather, whatever the role player says, we have to take those cues and add on to it. Okay, so you should not say, okay, I understand that you have a problem. I'm sorry to see that you have a problem. You also have to take cues and to ask more questions to bring out, the finer points. Then, so that's about the history of the presenting illness. Of course, in the beginning, as many people have mentioned here in the chat, if you see the confidentiality. So in a young adult, I would always, when you are talking, when you're introducing yourself, so I would like to ask you a few questions before I discuss the management plan with you. I would add one line that I assure you whatever is discussed in this room today will be confidential. You should assure them so that they are able to bring out what their concerns are. Always you can ask them, if somebody come, she says, I've already told my mother. You can ask her, if somebody come with her today, is your mother here with you today? Would you like to include her in the consultation? Because she herself says, I have told my mother. Even if she hasn't told, if a young adult comes to you for any issues, now it may be this, or it may be a station on they're wanting contraception or wanting termination of pregnancy and so on, you should always encourage them to involve a parent. They may not agree to it and you cannot force them, but you should encourage them. I know you are very anxious about informing your mother, but it would be a good idea to involve her and to have a discussion with her, and it would help you to deal with the problem better. Would you like to do that? So these are the words you use. I know you are anxious. You first have to always acknowledge what they are feeling and agree to it. You cannot argue with the patient. You have to acknowledge, yes, what you are saying is correct, but this is my point. Would you agree? If she says yes, well and good. If she says no, I still don't want to involve my mother, then you cannot force them. In this case also, if she says, I have already told my mother, and you say that is she here with you today? She says no. So when you are talking about her next meeting, correct? You will say in the end, okay, I would I will arrange a next consultation with the consultant. It would be great if you would like to involve your mother to come along with you so that we can discuss with her as well. So these are the small things we should add in a station, depending on what the case is. Okay, because this girl has already told her mother, so she would be open to involving her mother. Maybe not today, but in the next consultation. Even if she doesn't want her mother to come, if it was another case like contraception or termination of pregnancy, you still would encourage a young adult to involve their parent or guardians along. Maybe not in today's consultation, maybe in the next one. You should encourage them. These are the small things you should add, like confidentiality, as many things people mentioned here, which is correct in the beginning. Okay, I would like to ask you a few questions, but everything discussed here is confidential. So that gives the confidence to the girl to give you all information. Fine. Then you ask about, now I'm going to ask you certain sensitive questions. And then you talk about, now since the history of presenting complaint is going on, you have to ask about the sexual history, which is relevant to this case. So have you had any, I'm sorry to ask you certain sensitive questions, but have you had any, are you sexually active? Have you had any problem during sex? Because she may be saying, I have abnormal labia because a problem in intercourse, or the boyfriend has told her. So of course she says, I don't have any boyfriend and I've not had sex before. It's fine. Still, okay, history of any vaginal discharge. She may be having an infection there. So these things then come next. And then you can talk about the menstrual history, and then go on to the medical, surgical, allergy history, and so on. Okay. Before we go to, again, still in the history of presenting illness, you ask about whether she's sexually active and if there's any problem in intercourse, okay, any discharge or gynecological problems associated. And then you also talked about because she's saying I cannot, since 1 year she's thinking on 1 year. So does it affect your day-to-day life? You have to clearly ask. Okay, and then she says no, yeah, I feel so. And then your mental health, all the depression, anxiety questions. Okay, so do you feel you're not able to you're not able to take interest in things? How are things like in school? And then so on. Okay, so yes, he did ask about school, yes, but add on to what about your friends? Have you talked to this about your friends? So then she'll say, okay, do you have a lot of friends? How are your friends doing in school? So just like general questions. She'll say, so she'll either say, okay, I have a lot of friends, but I have not talked to them because I'm embarrassed. Or she'll say, I don't have any friends. Then, yeah, so when you go to the social history, again, that is important. So who lives with you at home? Everything okay at home? She may belong to a vulnerable group, okay? Single parent or refugee or migrant, which means that her situation is even more problematic, and you may have to add certain things. Okay, so then smoking, alcohol, drug abuse, all these things are again important because they may belong to some vulnerable population as well. Okay, so this, please keep that template in mind: history of presenting illness, then menstrual history, then medical surgical history, and as somebody said, drug allergies and all. They are patient safety points, have to be taken in all cases. Then social history, which is very important in this case, or how are things at home, any vulnerable issue, relationships in the family, and mental health. So that will. Before that, something I forgot was about sexual abuse. Now, all these things, there might be a hidden agenda of something like a sexual abuse. Give me a second. So now, how do you ask about sexual abuse? So it has to be a direct question, but it has to be sensitively asked. So again, you can signpost that I'm sorry to ask you this. So, I'm sorry to ask you. Please mute your mics, everybody. Please kindly mute your mics. I'm sorry to ask this question, but at any point of time, now or earlier, have you been forced to have sex without consent? Okay, so you have to rule out sexual abuse in these cases. So maybe she's not sexually active now, but she has in her past some incident which is causing her to, project it in some other manner, like, if she feels her genitalia is abnormal. So do not forget sexual abuse. This is a very, very important safety point we must remember, especially in young people. Not only in this case, again, I say, coming for contraception, for emergency contraception, for termination of pregnancy, young adults, rule out sexual abuse. It's very important. This will also depend on how the role player is. Sometimes the role player may be very looking here and there, not directly answering your questions. All the more reason to suspect, there may be some hidden agenda, which we should not forget. Please remember, the hidden agenda doesn't happen in each station, but it might happen in one station in your exam. And it's very imperative that you discover that particular station. Okay, so that all comes in your history taking. Now, examination, we see the examination findings normal. Now, next thing is about the management plan. Now, we all understand. First, you have to understand, when you are thinking about this station, you understand, this lady, so she doesn't have any physical problem. She's doing well in school, socially all okay. We don't think any sexual abuse or Munchausen syndrome or any problem. Only she has looked at the internet pictures. She thinks it is abnormal and she's very firm on that. And this lady has capacity. She understands what's happening. Now she keeps talking to you, Jeet, that, I've seen on the internet and these are abnormal. And I think my labia is abnormal. But you did not reply to her concern, which seems to have stemmed from the fact that she has watched something on the internet and she believes it to be true. So what I am trying to emphasize is, when we are communicating with the patient, the communication means it's an active communication. So she says something, you have to respond to it. Now she tells you twice, I have seen on the internet and it's abnormal. So you have to tell something about it. Now you have to answer that particular thing, which seems to be her source of thinking that it is abnormal. And she believes she needs surgery, which you think she doesn't need. So from your point of view, she's a young girl, only 16 years old, and everything is normal and she doesn't need surgery. Now, how you are going to convince her? First thing, when she keeps on talking about internet, you say that, first thing you told, the one correct thing was that the appearance of the genitalia or the private parts or the genitalia is very diverse. So if we consider all women, they have different size and shapes of vagina and vulva or the labia, and all are normal. You say that they have normal, they are very diverse, they have different shapes and sizes, and all are normal. And there's a great wall of vagina. You can say that this is a chart which is called as a great wall of vagina. It shows pictures and it shows that these are, variety of appearances of the genitalia, which is all normal. And then you have to tell her, so that's first thing which Jeet told. Yes, that's just normal. Then you say, the second thing you have to explain is about the social media and the internet, which seems to be her source. You say that I know you have watched, I see that you have watched the pictures of the labia on the internet, on social media, but you must understand that these images which are shown on the internet do not show the true picture. Many of these images are retouched, and this kind of pictures are the real appearance of a very few women. And most of these images are distorted or retouched. This is not normal for everybody. So you have to emphasize that what she's seeing on the internet is not the reality. It is showing the picture of what is the anatomy in a very few women, and these are all retouched or maybe distorted images, which is not the real thing. And then you say that this is you show the chart of the great wall of vagina, that this is what is real. This is all these variations are normal. Then third thing you have to explain is, which Monica added in the end, is right now you are 16 years old. Your genital tract, the genitalia or the labia is still developing, and it will normally, these physiological changes, they keep on going on till the age of 19 years. So since the development is still happening, doing any surgery or intervention at this stage can do more harm than good. Okay, your body is in still a stage of transition, and the risk of unsatisfactory results is higher if it is done at the age when the vagina or the vulva is still growing. Okay, because the normal growth of the tissue will be altered, it will be changed. Then you have to talk about the surgery. Now, that surgery will have its risks. There are certain short-term risks, the bleeding, infection, urine infection, and and short-term problems. And then you talk about the long-term issues like scarring. There may be the long-term effects, may be complications, like some people even have difficulty in intercourse. There may be physical deformity because of the scarring. And we don't have long-term data or research to show that these surgeries will yield good results. Also, you have to tell her that these surgeries are not supported by the NHS. So they're not funded by the NHS. So this also has to be told. So there are various aspects. So you have to tell the pros and cons. So important thing is not to be dismissive of her, that she says abnormal, you say normal, it's not a fight between two. You say that I know what your concern is, and you can, always it's a good thing to say in the third person. Okay, many girls at your age feel the same. So that gives an idea that you understand what she's going through, and it's something. Some people feel it. What you're feeling is a problem. Please mute your mics, everybody. Please. It's a problem many young girls face at your age, and now you are putting the facts in front of her. So it's never I against you. It's never you are on the same side. Okay, so you have to understand the concern, hear her out, and then talk about what I've told you. So these are the points we added. General measures which you can talk if she says I physically feel abnormal, that I feel some discomfort, then you avoid too much washing, harsh soaps, wear comfortable underwear, hair removal. So these are the things you can talk about, just as a general measures. Now let's see the domains which I've added some points which we must remember not to forget. Information gathering, as I said, presenting complaint in detail, the duration of the concern, how the concern originated in a case, impact of the problem on day-to-day activity, impact on the problem on mental well-being, ensures it's the girl complaining, not anyone else. social, gynecological history, medical history, issues at school, ruling out sexual abuse or assault. Then the domain on applied clinical knowledge, comprehensive evidence-based clinical knowledge, explains to the patient that there is a great variation in the normal and size and shape of vagina and distortion in popular culture, no relation between the appearance and the function of the labia. Then short-term complications of labial surgery, long-term complications like neuropathic pain or permanent injury, physiological development continuing about 19 years of age, not available in the NHS, and measures for maintaining vulvar discomfort. And then you say that, sorry, I forgot about the psychological support. So one is the consultant input and second is the psychological support. Now, when you are offering psychological support, also it's important to be very sensitive. You say that I know you're feeling, and many girls face this issue and they are troubled and very anxious about it. Sometimes talking to a counselor might help you to deal with this issue and to understand it better. Would you like me to arrange a consult with a counselor for you? So you should offer it. You shouldn't say, I'm going to refer you to this, that. No, you say that talking to a counselor might help you, as many girls face this anxiety and concerns. Would you like to have an appointment with a psychological counselor? So then they are more receptive to the fact. So I'm just talking about how you are going to communicate. What you are saying is correct. She doesn't need surgery, but you have to, she's very anxious, she's very concerned. So something has to be done for her to understand that what you're trying to say is, because unless you tried sensitively to explain her the way you talk, the words we use, it's very difficult, to assure her. The next domain is the patient safety, assessing the concern, trying to involve family members, inquiring about sexual activity and sexual abuse, safeguarding. So if you feel during the course of your consultation that there is some other, things involved like grooming or sexual abuse or anything, then you have to talk about, then comes the issue of safeguarding, maintain the patient dignity and open and honest about treatment. So we have to talk about clinical effectiveness of that surgery versus the patient satisfaction as well. So both the things you have to consider before you give your points. Okay, that's a repeat. So communication with the patient, introduction. So I must say that Jeet, otherwise overall your communication with the patient was nice. It's your tone of talking to her, the words you used, they were quite non-threatening to a young girl. So it was good. It was overall in a nice environment. Of course, you need more meat or more things to convince her, but that's fine. It's just it's a practice thing, so we can take time to develop our mind to apply them to various situations in various patients. So dealing with the issues sensitively is very important in these cases. Explain in layman terms, information, give information in chunks, checking patient understanding at regular intervals. Acknowledge concerns, don't brush away. That's very important. Because if you try to brush away what she's trying to say, then she's never going to be convinced. Responding to non-verbal cues and written information. So in the end, you say, I'll give you this guideline, which is the British SPAG guideline. This is the British Society for Pediatric and Adolescent Gynecology guideline on labiaplasty. Okay, quickly, I'm short out of time and Dr. Hassam is waiting, but quickly. So when you go back, when you talk about dealing with young adults, you should read about Gillick competence, Fraser guidelines. Sorry, I missed it. Confidentiality, which each station you should talk about confidentiality. You should always remember safeguarding issues, sexually transmitted diseases. We should remember offer sexually transmitted disease screening. Suppose this patient says, I am sexually active, you should offer her sexually transmitted diseases screening. You should offer her, talk to her about contraception as well. Whatever case it may be. You should use this opportunity for telling them about sexually transmitted diseases, contraception, and using safe sex practices, irrespective of the case.
Hello. Madam, can you please repeat the British guidelines that you just mentioned?
The British Society for Pediatric and Adolescent Gynecology. That's a Brit SPAC guideline.
Thank you very much.
Then the next issue is the Gillick competence. So this is used in medical law to decide whether child under 16 can consent to his or her medical treatment. And that depends on the emotional and intellectual maturity and ability to understand treatment. I'm not going into the details. You can read about it, just touching on the points. Then the Fraser guidelines, this is basically, it was designed for contraception, but now it is used for contraception, for abortion, termination of pregnancy, and sexual transmitted diseases. This is the contraceptive advice and treatment given to child under 16 without parental consent. Prerequisites of Fraser guidelines: girl understands the device. The professional cannot persuade her to inform her parents or to allow them to tell the parents that she is seeking contraceptive advice. She is likely to begin or to continue having sexual intercourse with or without contraceptive treatment. That unless she receives contraceptive advice or treatment, her physical or mental health or both are likely to suffer. That her best interests require him to give her contraceptive advice, treatment, or both without parental consent. Then under 13 years, must remember there is no lower age limit for Gillick competence or Fraser, but those under 13 are not legally able to consent to any sexually active, even if they're competent. This is one blanket rule. 16 to 17 years. So this is below 18, but 16 to 17 have the capacity to consent to medical treatment, in which this girl, it's not under 16 to 17, it is 16 to 17, sorry. Just ignore the under. Refusal of treatment can in some circumstances be overridden. If the refusal to treatment is affecting the life or is a threat to the life, overriding duty is to act in the best interest of the child. Circumstances where refusal would likely lead to death, severe, permanent injury, irreversible mental or physical harm, then you can override. Under 16, which is not Gillick competent, someone with a parental responsibility can consent for them: child's mother or father, child's legally appointed guardian, person with a residence order concerning the child, local authority designated to care for the child, local authority or person with emergency protection order for the child. I will go further. Under 16, you have to remember about safeguarding. So if a young person under 16 years presents to a healthcare professional with a safeguarding concern, if they are not Gillick competent, so then the health professional is obliged to raise the issue as a safeguarding concern and escalate through the safeguarding process. So when you're talking about the safeguarding process and all, just remember that you say that, I will inform the hospital safeguarding team. Even if you don't know anything else, just say hospital safeguarding team. So then who will be involving the police, the social services and all, who would take care of this matter. So it's easier to use this term, which I use for my station. If they're Gillick competent and disclosure is considered essential to protect them from harm or in the public interest, they should escalate the concern through the safeguarding process. Now, the difference is, if it's a young person and you have concerns about safeguarding, you say that then you have to break confidentiality. Okay, you say that I'm sorry, I'm worried about your safety and I have to break confidentiality and report it to the hospital safeguarding team. But basically you inform the person that you are going to break confidentiality and inform to the safeguarding team because you are concerned about the safety. Of course, if it is an adult and doesn't want to involve the police or the social services, you cannot force them. But a younger adult under 16, if there is a safeguarding concern, it is your duty to inform the safeguarding team after informing the child. Okay, any quick questions? After this, I would hand over to, I think, Mafia, who would be talking about the course, and then Dr. Hassam will be taking over. Thank you, all of you, for your very active participation, and I'm very pleased to see so many people here, and I think it was a very good discussion. I really enjoyed it. Over to you, Mafia.
Thank you, Dr. Pooja. It is nice session you mentioned. It is very helpful. Thank you.
Thanks, ma'am.
Mafia, you're there?
Yes, Dr. Pooja, thank you so very much.
Yeah, you can carry on. Yeah, okay.
So, hello everyone, can you hear me please? Your thumbs up will tell me that you can hear me. Okay, first of all, I want to introduce myself. This side, Mafia from the backend team of Med Exam Expert. So basically, I want to tell you about our course. First of all, if you want to join our course for the November attempt, what you have to do is you have to drop in a message that you want to join our course. Basically, our course was started on 10th of July, 2021. It's a 3.5 months, 3.5 months course, and our mentors are Dr. Pooja, Dr. Mohamed Hassam, and Dr. Sidra Ali. So first of all, if you want to know about the fee will be 550 pounds, but there is a gift for those who have attended our webinar. So first of all, I wanted to tell you that our course features. Basically, there will be camera on stations, and then we have a module-wise interactive sessions and live clinical case presentations followed by the feedback. We have a study groups where you can ask any of your questions from your mentors. There will be one-to-one mentorship. And in case if you have missed any of your session, you can listen to the recordings. Then we have focus key sessions during your course. Then we will provide you with GTGs, NICE, and talks on our website. And in case if you want to listen to the lectures, then we can provide you even our orientation videos first, just to select the whether you have to join this course or not. This is our course schedule for the November candidates. So if you really feel that you can adjust your time according to this schedule, you can join our course. And if you think that you don't have time, you can even listen to the recordings and you can ask any of your query in our study group. Mentors will be there to guide you. Now there is a gift for all those who have attended our webinar. We are offering 50% discount. So if any one of you wanted to join our course, whether as a listener or as an active participant, you can join our course on 50% off. Yeah, definitely. Reha, I'll get back to you, okay? Thank you. So here, what you have to do is you have to add this coupon, EAT50. How you have to add this coupon? So what you have to do is how to register the course. First, you have to go to our website. Link is there. I would request backend team to please send the link in the chat box. So what you have to do first, you have to click here in the sign up button to create your account. After that, you have to go to the course catalog, and then after that, you have to select your course. Let's say this course is for the November candidates. They have to select this link. After that, you have to click on this course. Once you will click on this, then you have to proceed with the checkout. Here you have to add your coupon, which is EAT50. Once you will add your coupon, your payment will change from $778 to $328. Okay. So if anyone of you have any question, you can ask me. You have 50% on active as well. It's just for 3 days. Nehla, yeah, sure, you can join. Yeah, there is a group discount too. Thank you.
Just want to add, there are 14 sessions for the 14 modules. One introductory miscellaneous session which already happened, and there will be 2 topic discussion sessions which are lecture based, and then one special session on structured discussion. So it's, I think, around 17 to 18 sessions in total.
Yeah, Dr. Pooja, one student is asking for the schedule. Sarah is asking for the schedule. Sarah, I'll share the schedule in the chat box. Okay, thank you.
And Dr. Pooja, will it be EBCOG-2 oriented too?
Yes, I think Dr. Hassam will be talking about EBCOG as well. He's just
Okay.
waiting for all of you. I think we'll just hand over the mic to him. Okay. Thank you. Thank you.
Okay.
Thank you all. Thanks for joining.
Thank you, ma'am.
हम डॉक्टर हसन आए, उसने हमें पार्किंग में भी पढ़ाया था, इजिप्ट कायरो से।
Is it my turn to start talking? Mafia, am I right?
Yeah, Dr. Hassan, very warm welcome in the session. Students are waiting for you.
Excellent. So good evening, everyone. I'm very happy to join all of you today for the preparation or introduction course for Part 3 MRCOG, as well as the EBCOG Part 2 OSCE exam as well. My name is Mohamed Hassam, and maybe some people may know me before from Part 2 preparations, or if you don't know me, I'm Part 2 instructor and lecturer in the RCOG, and accredited clinical examiner in Part 3 MRCOG as well. And I hope all of you will gain the maximum benefit from our journey during the preparation. Yes, I will open the slideshow right now. Just a second, please. If the voice is clear, and now, just a second. Okay, let's start sharing the screen. And if the screen is clear as well, just just inform me to start my session with all of you. Yes, excellent. Thank you, Tihal. Thank you, Salma. And thank you, everybody, again. Actually, I enjoyed a lot the session by Dr. Pooja. She added a lot of information for me as well. I gained the maximum benefit. And thank you, Mafia, for your summary about the basics of our course. It's not the first time to conduct a course for Part 3 or the OSCE preparations as well. So we assume that you all will be enjoying a lot the experience of this course. Now, I choose somehow a specific topic to discuss with all of you about a very important technique to be evaluated by the exams, which is the breaking bad news. How can we tell the patient about a difficult situation? So the breaking bad news actually is an art you should understand very well as you should follow the steps so that you can gain the maximum mark in the exam. Okay, these stations are mainly testing the candidate's ability to counsel. How can you tell the patient about a very difficult problem? How can you tell her the basics of knowledge? Don't never go in details. And how you will respond perfectly to her emotional situation. For example, she may cry, she may screaming, she may attack you aggressively, she may do anything. So you should be able to absorb any action by this woman or this patient, I mean. Most of situations are related to oncology, how to break a bad news regarding the patient's results, regarding the positive cancer results, for example. Sometimes the situation may be related to a fetal medicine. A woman underwent a congenital anomaly scan and she is so anxious about her baby. Actually, the anomaly scan revealed lethal anomaly. Okay, how can you explain the situation for her? This technique is difficult, but it's very important to be understood very well by the candidate. Now, if we would like to simplify the situation, let me say we have a very important two techniques. Before starting to discuss the techniques and to apply it in our example, you have to remember these important points. Number one, the final decision should never be taken in this appointment. For example, a patient with ovarian cyst, ovarian cystectomy done successfully, and the histopathology revealed adenocarcinoma grade 2. Okay, I will tell her that we have a cancer, but I should never tell her about the details. How can we manage this cancer situation? Okay, I will concentrate too much on supporting her in this appointment, either by her family, by friends, by myself, offering the MDT further appointment, but I should never give her an extra burden by discussing the details, the awful details of the cancer treatment, like chemotherapy, like hair fall, like severe vomiting and pain and blah, blah, blah. It's not the ideal time. The second thing, don't offer from your side to discuss different points or details. For example, don't discuss with the patient, one, what is the next surgical step, two, what is the chemotherapy ideal to be used, number three, positive or negative for radiotherapy, number four, if there is a palliative treatment or something. Don't offer from your side to discuss different points. So what should you do? I should follow the patient's agenda. I will ask her, what you would like to discuss with me? Tell me about what's most bothering you right now, and answer precisely to her queries, precisely to her fear, to her agenda, not your agenda from your mind, okay? Because sometimes the situation may be very easily to be managed, while you, from your point of view, it's complicated and difficult. And this is normal, because you are a doctor and you are thinking like a doctor from all aspects, while the patient not understand many things. So just follow the patient's agenda. And how can you apply this? And this advice is not for breaking bad news only. It's for all stations in the exam. Please listen more than talk. I know this is a very difficult thing for all of you, including me as well when I was a candidate, because I have a lot of informations in my mind, and I would like to express my knowledge to the examiner to gain more marks. Actually, this is a major mistake. Don't talk too much. Listen and answer precisely. Give the patient targeted answers. Number one, you will fulfill the hidden agenda of the station. Number two, you will minimize possible mistakes from your side. When you talk less, you will decrease the possibly mistakes. When you talk more, you are definitely opens different doors, which sometimes may be difficult to be closed, okay? Especially in 10 minutes. It's impossible to discuss everything in 10 minutes. You have to believe in that. So you have to select the most important points to discuss. How can I do that? By following the patient's agenda. Now, the pitfalls that most of people may fall in, the candidate fails to read the question properly. And this is not only as well in breaking bad news, in any station, under the severe stress of the real exam, under the short time management, you may fail to read the question. I always recommend 1 minute to read the question, and the second minute to ask yourself, what is the aim beyond this scenario? If you catch the aim, you will manage the scenario appropriately. So read the question first very well. Even if you felt that the scenario is a recall, it's very familiar scenario. So I will go directly to prepare my answers. No, it's not like this. You have to read very well. Number two, the proper timing to break the bad news. As I said before, we have two possible techniques to break the bad news. The first technique is you will start the session with the patient as ordinary. You will introduce yourself. You will take a proper history from the patient, I mean information gathering, and then you will start to break the bad news. The other technique, which I recommend strongly, is start the session by breaking the bad news. And then you can go back to take information gathering or to ask about detailed history. Tell me why. Because sometimes with many candidates, and I saw it a lot of time, the candidate, if started with history taking, it may be time consuming, okay? And actually the station and the patient questions will be more than expected. So most of candidates at this point may not fulfill the station up to the end. The time will be finished while they are still struggling to cover every point in the patient agenda. If you start with breaking bad news, number two, it's psychologically better to the patient. Now, put yourself in the same place of the patient. If you have a biopsy, for example, from a mass, and you are waiting to know the results, and you discover that the doctor in front of you is asking you a shit questions. When was your last menstrual period? If there is any discharge, pain here or there, what are these questions? Please tell me about the results of my biopsy. Okay, so you will, if you follow the first technique, sometimes the role player may attack you. Doctor, please tell me about the results first. And then you will be so much anxious because you have to change your plan. So I recommend strongly to start talking about the problem first. After relief of the problem, you can start asking about any questions you want, or what about the most important things regarding the patient's mind. Okay, this is important. Number three, expectations to all possible reactions by the role player. Don't be surprised. Don't be afraid. The role player has a plan and she will fulfill it. So you have to expect whatever from the role player, and you have to adapt. You have to be very formal in your actions. Don't smile. Don't try to be funny. Don't even call the patient by her first name. For example, a patient, Elizabeth Keene, for example, okay? You have to tell her Mrs. Keene or Miss Keene. Don't tell her Elizabeth. Don't try to be friendly with the patient. You have to be very formal to prepare the patient for the bad news. Don't smile. Don't try to be funny. Be confident. Be ready. Be smart and be formal. It's very important advice in such situations, because what you are trying to do is simply to prepare the woman for the bad news. So you have to prepare her by your voice tone, by your facial expressions, by your formality actions. by being so much serious, okay? And please always ask about if there is any support or help, anybody she would like to join in this appointment to be with her at this moment. All of these steps are preparing the woman for the bad news, okay? These are a very rapid instructions. If you follow these instructions, you will find it easy to manage the breaking bad news. I suppose that breaking bad news station in the exam is a guaranteed station for success. You have to pass this station easily, either for MRCOG or EBCOG exam, okay? Because EBCOG as well, as we will discuss later, we have also breaking bad news station because it's extremely important, okay? Now, let's play, okay? I need one victim to play the next game with me, next station. I promise you will enjoy a lot, okay? So who would like to join the next station as a training?
Can I, sir?
Yes, of course, you can. You can. So be ready. You will read the scenario for 2 minutes, and after that, you should deal with me, and I will be your role player. 2 minutes from now. Read carefully, please. And please, my dear, start.
Hello, I am Dr. Abdul Qadir, one of the doctors in the antenatal clinic. May I confirm your name and age, please?
Hi, doctor. My name is Karen Woods. I'm 38.
Hello, Miss Woods. I understand from your notes that you are coming today to meet our consultant because the ultrasonographer has been referred to us.
Yes, yes. Actually, I went to the ultrasonographer for my routine exam for my baby. Okay, And you know, he makes me very nervous. I saw his facial expressions during the exam, and I was so worried about what's wrong with my baby. And then he told me I have to contact you as soon as possible. That's why I'm here today.
Okay, I understand your concern, Miss Woods, and I promise you that I will talk to you straight away and try to answer all your concerns.
Thank
First
you.
of all, thank you. First of all, Miss Woods, are you alone today, or you have your partner with you, or anyone of your family with you?
Actually, my partner is at work. He's so much busy, and yes, I'm alone actually.
Okay. Do you like to bring him to share us in our conversation, or maybe one of our colleagues or chaperone to be present?
It's fine. It's okay for me. No problem. So, is there a big problem you have to talk me about?
Actually, Miss Woods, I have no good information to tell you because the ultrasound, the ultrasound revealed that your boy or your baby has certain congenital abnormalities in
Oh my
body.
God. Oh my God. I thought about this. Oh my God. Mm-mm. I can't believe. Are you sure?
Yes, I'm sure.
Is it maybe any mistakes with the ultrasound or something? Because I cannot believe that.
I'm sorry. I'm really sorry that I told you that bad news, and but unfortunately, this is the picture.
What kind of abnormalities? Is he gonna die?
Um, uh, actually, I
Please tell
can't
me,
tell you
please tell
this.
me frankly, is he gonna die or something? Is it a serious problem?
I'm afraid it is a serious problem, but actually we have to perform more investigation in order to reach to the final cause for these congenital malformations. Because most probably it's about the genetic makeup. It is a faulty genetic makeup from the start.
So you mean this is my fault? I mean, I have to blame myself for this problem because it's maybe my
No,
genes or something?
no, Miss Woods, no. This is not your fault at all. Because many of these cases where there is abnormality in the genetic makeup of the fetus, you are not responsible for it, okay, without a reason.
Okay, okay.
So
So
please don't blame yourself. Please.
I will try because I was so much happy with this pregnancy. This is my first one, and me and my husband was so much happy, and I don't know how can I tell him about this problem. So what do you think is how can we manage now? What should I do?
First, Ms. Woods, I advise you to we're going to refer you to the fetal medicine unit where there are more specialized persons there. They could deal with such cases.
Okay.
Besides that, at the fetal maternal unit, they're going to perform a confirmatory test for you in order to know exactly what is the genetic makeup or the faulty genetic makeup of your baby by forming a certain invasive procedure called the needle test. Do you hear about?
Actually, no. So would you like to tell me a little bit more about this option?
Yeah, the needle test it's called like that because with a fine needle, we try to take a sample from the fluid around your baby, and then we will culture it in the lab to know to examine this fluid for the genetic makeup of your baby.
Okay.
This will be confirmatory for actually the picture of your genetic makeup of your baby.
So is this needle maybe helpful to treat my baby? I mean, we can do something for my baby inside my womb to help him?
I'm sorry to tell you, I'm really sorry to tell you, if it is, the result come as it is, one of the syndromes that has an abnormal genetic or abnormal chromosomal pattern of your baby, I think nothing could be done for your baby inside your womb.
Okay, okay, I understand. So I'm so much confused right now, and I think I cannot take a proper decision regarding that. What about my options if I would like to terminate this pregnancy?
Yeah, this is one of the options. If you like to terminate this pregnancy, you could have this option because you are less than 24 weeks pregnancy now. So we could terminate pregnancy by give you certain pills, either taken by mouth or put it inside your vagina in order to terminate your
Time.
be able to. Sorry, sir.
No problems. I enjoyed a lot this session actually, and now let me ask you. Tell me about your actions. What do you think? What do you think the positives, and if there are any negatives from your point of view, tell me about.
The positive. I really I was sad for her.
Oh, wow, you're so emotional. But
Yeah,
this is a part of our career, by the way. The dark side of our career, actually.
Yeah, because she is 38 years. She is a little bit older, and also this is her first pregnancy. So she's actually
and
very
chances
bad
are so
surprise
much
for
poor,
her.
yes.
I also the Arnold Chiari malformation with lemon-shaped head and spina bifida. I think, sir, I'm sorry, I don't remember actually. I think this is it is related to Pateau syndrome, or it is I forget to which syndrome it is related.
Actually, let me help you to evaluate yourself and to explain to all our friends how the examiner will evaluate you. Now, please always remember the domains you are trying to fulfill: the patient safety, the information gathering, the communication, and the applied clinical knowledge. So let me say that I love so much your voice tone, your empathy with her situation, your calmness when you are breaking the bad news for her. You don't spend too much time. You tell her about the problem directly, very straightforward and the frank way. And you asked about the company for her. These all aspects, and you called her very formally, like Mrs. Woods, not a Karen or something. So your actions were magnificent. Actually, I liked it so much. So in communication, actually, I will give you pass. Especially, my friends, you have to remember a very important thing. Communications with the patient is not only exclusive. How can you deal with the patient in front of you? Communication always exclusively include communication with necessary medical team. So always in any station, you have to think about somebody to join you in this station. In this station particularly, fetal medicine consultant should be involved. And I can build up a lot on this basic information. I can involve psychological counselor to help her regarding her psychological trauma and to support her. I can ask for a neurology consultant because I have no good information about the outcome after delivery. Sometimes this woman may decide to continue the pregnancy. So I have to give her possible options about the outcomes. And the best one to discuss the outcomes will be a pediatrician neurology consultant, for example. So you have to join many people as much as you can with you in any scenario. In that way, you will gain the maximum mark in communications 100%. So I will give you pass in communication because of all of these points. Regarding the patient safety, I think you did a great job when you not giving her a certain pathway to go through or to run through. You didn't inform her that this baby will die, so we have to terminate pregnancy, for example. Or we have to continue and then we can see what is the outcome. You give her open options, you accept her wishes, you answered her queries regarding the termination or the possibly the middle, I mean amniocentesis, possibly to help her baby regarding his problem. You answered all questions in a very open way, no medical jargons possibly, and it was a very simple informations for an ordinary woman, not a medical field woman. So I liked it so much. Your applied knowledge, from my point of view, you answered in a very simple way, and I respect it so much. You mentioned in a very small hint regarding the termination of pregnancy and the relation to the gestational age. So it's also a respectable point. You have a reasonable time, about 1-2 weeks also more before taking a final decision. What I would like also to say is always insist that we will build up or we will prepare for further appointment with my consultant. This is not the only single appointment. And you have not to take a decision right now. This is a stressful moment. So any decision at the stressful moments most probably will not be appropriate. So you have to offer the patient further appointment. You have to offer the patient a meeting with your consultant and the multidisciplinary team so that they can provide you a better view and a better management plan. What is the trainee job description in UK? This is what you think about how can you manage any woman. The trainee is just the primary step in the medical management plan. The trainee should never take decisions. The trainee most probably will just prepare for their consultant appointment, okay? If you understand this principle, you will manage any case from a very calm situation because there is no burden about you, no need to discuss the details of any problem. If I told you that the baby has XYZ syndrome, which is extremely unknown and extremely rare, I have nothing about this syndrome, no information is in my mind. It's not scary because the management will be the same. I will ask the fetal medicine consultant, I will refer you, I will prepare for further appointment, and I will involve the psychological counselor. Do you have any queries? Do you have any problems you would like to discuss with me? It's the same technique, okay? What do you think, my friend, regarding the negatives? I talked about the positives. Tell me about the negatives from your point of view before telling you about my negatives.
Um, I think because it is always my problem that I finish after the time. So I didn't finish here.
This is number one.
What I'm saying.
Excellent.
Because actually, sir, I want to listen to her. I wanted to debrief her indirectly, but I think this is not be applicable at the exam.
So you think that the time is not enough for you, but actually, I will give you pass all over this station, even if the whole questions are not fulfilled by the 10 minutes time. Tell me why. Because you spend 10 minutes in a very good performance. So the examiner will believe that if I give you 10 minutes more, you will act appropriately and you will do a very good job. So what I would like to say is we are not 100% evaluating the candidate through the 10 minutes. I'm just evaluating the candidate through is he or she did a great job or did it well or not. Because all of you knows that 10 minutes is very limited time to fulfill huge stations, sometimes like this. So despite the time was not enough for you, but it is never a problem in your marking sheet. So you will pass the station, and I cannot express how much you did a great job in this station. I like your actions. You did a great job. I'm so happy.
Thank you, sir. I'm really flattered, and I don't deserve those great words. Thank you very much, sir, for your kindness.
You 100% following the instructions and did it perfectly. Now let's go to see the examiner's key. In communication domain, clarity of speech, avoid jargons, you did it. Involving other medical team, like fetal medicine consultant, psychological counselor, pediatrician, neurologist, or something. Showing empathetic approach towards her condition. Now, this is copy-paste examiner's key from the real exam. Now, you please notice that I would like to show you something. Notice that the asterisk landmark at the involving medical team and empathetic approach towards her condition. Now, in the examiner key, we are finding most probably 2 asterisk landmarks at 2 important points. What does that mean? It means, for me as evaluating examiner, if the candidate missed one of the 2 asterisk points, I can never give him 2 out of 2 marks. I cannot do that. For example, if you showed empathy perfectly, but you forgot to involve medical team, whatever you did in communications, I will give you 1 out of 2. It's obligatory. Okay, it's obligatory. Now I am giving you the hidden part, the hidden aspect of exam evaluation. That's why many candidates are getting inside the exam and they did very well, but after that, the results may be non-satisfactory. They may not pass the exam. And they ask themselves, why? I did it perfectly because of the asterisk. Where is the asterisk points in the examiner's key? I'm giving you a direct example from the real exam. Now, involving medical team and empathetic approach. It doesn't matter for the examiner if you did these 2 missions perfectly. If, for example, you by mistake used a medical jargon, I will never give you 1 out of 2 because of medical jargon. Never. Okay? But I will give you 1 out of 2 if you missed 1 asterisk point. If you miss 2 asterisk points, I will give you 0 in communication. Even if your speech is clear, if you're confident, if no medical jargons, I will give you 0 in communications. Okay? So you will gain 2 out of 2 in communications, my dear. Information gathering. Obtain relevant history, family history is very important, and psychological history. Despite you missed, but I will evaluate you as okay because you mentioned possibly genetic problems, okay? But at that sake, you have to explore deeply or more the positive family history for genetic abnormalities, the psychological condition of the patient if she needs psychological counselor. Examiner's key: patient safety, ability to identify patient's concerns. You did it perfectly. Ability to offer support, and you did it when you asked about her partner or her family, anybody to join. And please don't forget to offer psychological counselor. Whatever else, respect patient decision, give her options, spikes of breaking bad news technique, it doesn't matter if you fulfilled the asterisk points. And finally, the applied clinical knowledge. What about the termination of pregnancy, logic plan, multidisciplinary team with neonatologist or pediatrician if she would like to continue the pregnancy, possibility. Don't refuse any option to be non-judgmental approach. This is a very important evaluationary point in any exam. Don't be judgmental. If you have a fertility station and you are managing same-sex couple, they are asking for pregnancy with IUI, donor insemination. Sometimes this station may be so much difficult for anyone with strong background against such act. You should never be judgmental. You should smile. You should accept those people, okay? Addict patient, sex workers, you have to accept them. Don't ever, never show any judgmental action, okay? And finally, offer the support groups, psychological counseling, and maybe you can give her some leaflets. That's why you gained 2 out of 2 in communication, 2 out of 2 in patient safety, 2 out of 2 in applied knowledge, and 1 out of 2 in information gathering, and then you will gain pass in this station. Now, before going to discuss the EBCOG exam, I would like to hear from all. Yeah, thank you so much for your participation. I enjoyed a lot, actually. And if anybody have any additional points would like to share with me regarding this station or similarly stations, please, it's the time. Write something on the chat room, open your mic, talk with me. I will be happy because sometimes many people may add a very strange points, but it's valuable. So I'm always happy to listen. Anybody would like to add anything after this explanation?
Hello. Hello, Dr.
Hello.
Hassam. I'm Homa. I'm Homa. I was your student in MRCOG-2 as well.
Excellent.
Hello.
How
Nice.
are you? I remembered you. How are you?
Yeah, I'm great. Thank you very much. It was nice to hear you. I just wanted to ask one question, is that when you're explaining to the patient that the ultrasound shows a congenital abnormality, do we have a better word like a birth defect or something rather than using the word congenital abnormality? Will that be very clear for the patient? And secondly, when you start
exactly.
Yeah, and the other thing is that when we start with the breaking of the bad news, most of the time we miss the information gathering because from the bad news we go on to the management and then the rest of the things, and this part is usually missed. Like in our practice sessions also, whenever we start with the news, the bad news, we miss the rest of the part, the rest of the domains. And, it's just like, missing the one of the domains. So maybe the way you've evaluated it works, but maybe there are examiners who really want that we should be touching every domain. So how does that sound? I mean, we can bypass a domain
Yeah,
and,
let me explain this.
Yeah.
Let me explain this point. 2 points. Thank you so much. Of
Thank
course, the expressions, for me, for example, if I would like to explain Arnold Chiari malformation for a patient, I will say, for example, yes, the ultrasound unfortunately revealed that your baby have some troubles in his brain. Okay, this is more than enough. Some troubles with his brain that may affect his life and may be later leads to permanent disability. This is simply a very simple sentence, and the patient will accept and understand in a very easy way. Don't try ever to use complicated expressions. I accepted the anomalies or abnormalities expression because it's considered a common expression in UK. For example, I will give you a very simple example. Previously, we were instructed to say neck of womb for the patient, okay, rather than cervix. Now, cervix is a very acceptable expression. Worldwide, it's very well known that the cervix is the neck of womb. So no need to say neck of womb anymore. This is an example. So abnormalities is accepted expression. That's why I accept this expression from our friend who participated in the station. But for myself, I prefer or I usually use more simple expressions like defect, problem, okay, affecting the baby's brain, not a CNS, for example, baby's brain, baby's heart, baby's tummy, okay? So whatever the situation is, okay? But your point is so much respectable. The second point is regarding if you started with the information gathering or started with breaking bad news. Now, the breaking bad news, if you started with breaking bad news, of course, you may miss some important points in history taking, but it's all depending on the practice. If your practice is regularly to break first, you will find yourself easily, automatically start to information gathering plan rapidly after the breaking bad news. Just even to distract the patient's concentration about the problem. If your regular practice is to take history first and then start to break the bad news, I think it will be more easy for you. I recommend breaking bad news first. But if you are not well trained or would not like to start training by this way, you can start by taking history first and then breaking bad news. Both techniques are regular. But what I am afraid from is some people may take a lot of time, 3-4 minutes in history taking. So I will be so much afraid to lose information gathering. However, you may gain 2 out of 2 in information gathering if you started with, but you may miss other domains. So that's why I prefer the second way, to break bad news first. But it's not mistake if you are well trained to obtain medical history rapidly in 1 or 2 minutes, it will be ideal as well to use the first way possible method. Okay?
Thank you. Thank you very much.
Thank you. Thank you, Homa. Thank you.
Sir, can I ask
I think the breaking bad news, yes, sure.
Yeah. So can we give the patient an option, like using a sentence like, do you want to really know about the result first, or is it okay if I ask you a few questions to know more about you? That
yeah, yeah. This option is a very good option. It's possibly to offer the patient if she would like to know the news first, or we can discuss a few questions before discussing the news. It's a good option, but if you sometimes you have to be so much sticky to a practice, a certain practice. What our seniors always told us that don't try to do anything against your regular practice. This is what I'm trying to say. You have to be very natural in the exam. The examiner always feel the candidates in front of him. Is he in a natural mood, or he is trying to or pretending to act like professional doctor? If I felt at any point that you are pretending to do something against your regular practice, I will catch you, okay? And I will give you a very bad mark. So
it will look like a role play in itself.
Yeah. Don't try to look like a professional doctor. You have to act simply like what do you regularly do. And that's why you will find multiple schools of training for OSCE exams. You may somebody preferring to start with breaking bad news like me. Somebody will start to taking history. Some other doctors may ask the candidate or the role player, what would you like to start with? Okay, so what I strongly recommend is all of these methods are correct. All of these pathways are correct if you reached your target at the end. But what I strongly recommend is do whatever you regularly do in your life, okay? Because it will help you to be more easy and more calm and more comfortable inside the station. All of them are true. Okay?
Yes, thank you so much.
Yes, thank you. And always try to use a very simple words. Okay? Always try to, from now until the date of the exam, try to build up good sentences to be used at any situation. It's like a defensive mechanism, okay? Defensive mechanism. If the patient asked me any question, I have a certain sentence in my mind, I will answer. This is by practice and will be very helpful to all of you to answer any question at any moment without being surprised or hesitated. And this is very important to confirm your confidence level at the examiner and at the role player as well. Okay? Excellent. Thank you so much. All of you are so much active, and all of you indeed are in a very good level. And this is very important. Okay. I will take it. Yes.
Can I ask you one question?
Yes, sure, please.
Yeah. So actually, in this case, patient didn't mention that to continue the pregnancy. So
yes.
If patient wants to continue pregnancy, that means we have to explain her that antenatally how we manage her with more scan, and also that plan of delivery. And after delivery also, if she will ask the baby how we teach the baby, is there any treatment or anything that baby doctor will do? If she will ask, then we have to answer also. And also the recurrence rate. If first baby there is a spinal baby, then second baby also there is a possible that could be. And also that contraception advice also to prevent the unplanned pregnancy, because she will be mentally upset for this baby. So do you think all of these things we have to mention if she wants to continue the pregnancy? And when she asks you that what is the, that is it my fault that I have done something, that's why it happens. So what you will explain in your words, please. Thank you.
Okay, thank you. Number one, if you would like, this is one of the major mistakes by all candidates, because from station to another station, there is a big difference, and not all stations you have to apply the full steps of obstetric stations like antenatal care or preconceptional, antenatal, intrapartum, postnatal. Not all stations you have to fulfill all these aspects, because if simply you try to fulfill all these domains, you will keep talking at least for 15 minutes without listening to any query of the patient. And then believe me, if you did that, you will never pass the station, because the aim of the station is to evaluate multi aspects, not only your a very good knowledge to manage a patient in high risk pregnancy or a difficult pregnancy. So not all stations requires full evaluation or full fulfillment of all points regular discussing in obstetric cases. This is one of these stations. The main issue is breaking bad news, not to cover all pathway of this pregnancy. Sometimes if the patient planning to continue the pregnancy, you have to mention very simply that because of your problem, your visits will be more frequent. You will be evaluated in consultant-led unit under evaluation of multidisciplinary team involving 1, 2, 3 doctors. Your delivery will be discussed around 36 weeks, and your postnatal care will be discussed later after delivery in aspects of breastfeeding and contraception plan. So we have to involve a pediatrician and the neonatologist to evaluate your baby's condition. Now you show the examiner that you understand the principles of antenatal and postnatal care. But if you start talking in details, you will never finish the station at the time. Now, how can you evaluate? Is the station, if the discussion of antenatal and postnatal fully required in this station or not? Ask yourself a question. What is the aim beyond this station? The aim is breaking bad news. So I have to concentrate mainly on the breaking bad news technique. All other things are auxiliary, accessory to the question. If, for example, the same scenario, but the baby is fine, the mother have a neurological problem. So now this station is not breaking bad news. This station is high risk pregnancy. So I should give 100% informations about how to manage antenatally, intrapartum, postnatally, high risk neurological pregnant woman. So always take a global view about the scenario. What is the aim beyond this scenario? Is it maternal or fetal? Is it breaking bad news or high risk pregnancy? And so on. At this point, you will be able to select the most important options in discussion, and then the less important. Less important, even if you not fulfill it, you will gain pass. Okay? This is regarding the first thing. Regarding the second point, which is when the patient asked the candidate about is it her fault or something, I think she answered her perfectly when she said, it's completely not your fault. It's a sporadic problem. Don't blame yourself or your partner. And she reassured her in a very good way. And I think I will say the same if I am in the same situation. Plus, Plus, I may add, if you would like me to have a separate appointment with your partner, I will be very happy to counsel him. This is a good addition offer. You may offer the patient, because sometimes the patient may be afraid to discuss these points with her partner. So I will offer you to sit with your partner in a next appointment to explain every single point. And I will be very happy to offer you an appointment with genetics, for example. Genetics, for example. It will be helpful to explain more for you the possibilities of genetic problems and how can we avoid it furtherly. Your mission is just to inform the patient about the problem, to reassure and accept her wishes and her feelings, and to reassure her and support her, and finally to redirect her through different consultations. This is your main job. I strongly accept her answer, I mean our friend answer, regarding blaming herself or how can she manage. But if you would like to be more sophisticated, you may add the further appointment with the partner. It will be also very helpful and very supportive. Okay?
Yes, Dr. Hassam, thank you for nice explanation. But do you think that from starting, if I'll ask you the patient that about the termination of the pregnancy and continue the pregnancy, which one she prefer, then I can, which way she direct me, then I can explain this termination pregnancy or that continue the pregnancy, any way, then it will be save my time. What do you think?
What I understood is if the patient, for example, told you, I would like to terminate pregnancy, what should you do? Or if she told you, I would like to continue pregnancy, what should be your action? Now, listen to these sentences, because you will use these sentences in any situation. Your action, whatever her decision is, should be, I think this is not a proper time to take any decisions. We still have time. And I strongly suggest that you need to discuss it with your partner, with your family, with your trusted people before taking a final decision. I will offer you a further appointment, especially with my consultant, because it will be more helpful for you to clarify your decision. And whatever your decision is, you will be fully supported by the whole medical team. Full stop. This is the answer. Okay?
So sorry, maybe I didn't explain you properly. What I wanted to say that, do you think that the termination of the pregnancy, the management plan, and also to continue the pregnancy, the management plan, two is different? So do you think I'll explain both, then I'll ask the patient, what do you think? Or beforehand, I'll ask her that which one she likes, then according to this, I'll just explain only one, then to save my time.
The line is breaking, your voice is breaking down. Yes, Dr. Salma.
Yes.
Hello?
Yes, now, is it clear now?
Now it's clear, yes.
Yeah.
Yes, now it's clear.
So do you think that termination of the pregnancy and to continue the pregnancy, it is two different ways to manage, isn't it? So
yes,
I'd explain the patient that both options, how I manage to her. So it will take time, more time I need, isn't it? So otherwise, I can ask her beforehand which one she likes. Agreeing to this, then I can go only one way, which one patient likes. If she likes termination of the pregnancy, then I can go only this way. and no need to, and I can shortcut, I can tell, continue the pregnancy, this is another way we can manage you. But this one she doesn't like, so no need to mention. Otherwise, if I mention both way this, management plan, then it will take time, and maybe I lose.
Unfortunately, this is an unavoidable situation. What I would like to say is, one of the most important things in exam is to offer the patient all possible options for her. Now, in this scenario, she has two possible options, either to continue or to terminate pregnancy. I helped the candidate when I said, what about termination? Okay, but actually, the real scenario may be, I will ask her, what should I do right now? So you should offer the patient all possible options, even it will take time. You have to discuss termination of pregnancy, what will we do? We have to discuss the continuation of pregnancy and what should we do in this situation. I will give you another example, a very famous example. A patient with heavy menstrual bleeding. I have to offer her all possible options, despite, for example, Mirena is the ideal, but I have to tell her that oral pills may be used, tranexamic acid may be used, surgical intervention may be a solution, Mirena insertion, blah, blah, blah. All of them should be offered with pros and cons. And then the decision is the patient herself. So I know it will take time, and this is what we have to train about, is to utilize every second in the station perfectly so that I can express too much information in a very limited time. But I cannot ever, never direct the patient towards one option or two possible options without offering her all possible options. This is called paternalism, okay? And paternalism is not accepted action by the UK practice, in the UK practice, okay?
Okay, thank you very much.
Thank you, Salma, thank you. I will take 10 minutes more. I know it's too long now. I will take 10 minutes more just for those people who are interested in the EBCOG exam. The EBCOG exam is following the old-fashioned MRCOG exam, okay? Actually, it's evaluation as well for the OSCE skills, and some stations are directed directly to evaluation the skills or the technical functions, or purely asking about knowledge. The structure of the exam is 10 stations, including 1 preparatory station and other 9 marking stations. 12 minutes each, 1 minute for reading and 11 minutes for the exam itself. Please give me 1 second if possible. Yeah, I'm back, sorry. So it's 10 stations. 1 preparatory means no exam. You have to read the instructions well to be prepared for the next exam station. Every station 12 minutes, 1 minute for reading and 11 minutes mostly for the exam itself. The stations are as follows. 1 station will be regarding history taking and summarizing to a colleague with a scientific discussion. It could be any topic in obs or gynae, but most probably it will be a famous topic with a straightforward, famous guideline. Okay. The second station will be breaking bad news, and I think we explained the breaking bad news easily and completely. It could be whatever ultrasound finding, abnormal finding, infection, or cancer finding. The third station will be regarding the skills, technical skills. So basic obstetric technical skill, you will be examined on the model, maybe for breech delivery techniques, maybe for instrumental vaginal delivery, external cephalic virgin, whatever the skill is. It will be on a dummy or on a model in front of you. The fourth station will be the same as the third one, but for gynae skills. You may be asked for IUD insertion, or you have a dummy for hysteroscopy or laparoscopy. For me, in my exam, it was a transvaginal ultrasound assessment. So I have the probe in my hand, I have a patient, I mean dummy, leaning in front of me, and I start doing simulation transvaginal ultrasound under a supervision of the examiner. Okay. It was very interesting station, by the way. Okay. The station 5 will be explaining a clinical situation and establishing a management plan for obstetrics, as well as in station 6 for gynecology problem. Okay. Number 7 will be complex technical skills. You will be examined regarding obstetric emergency situation, like how can you manage shoulder dystocia, or how can you manage after coming head in breech delivery, postpartum hemorrhage, maternal collapse patient, and so on. So you have to show to the examiner your skills in obstetric emergency condition. Station number 8, it will be a preparatory station. Most probably you will have a paper to read it carefully, and then in station 9 you will be discussed by the examiner regarding this paper. However, it may be audit, it may be critical appraisal of scientific paper, it may be whatever. Okay, but it's most probably related to theoretical questions. Okay, it includes the evaluation of preparatory and after preparatory station. It includes evaluation for communication with the examiner, the basics of research principles, the study designs, and the audit understanding, sometimes the risk management and incident report evaluation as well. Thank you, my friend. And finally, the last station will be a clinical governance and risk evaluation. It will be a direct discussion with the examiner according to a malpractice, never event situation, and how can you manage it. So it's exclusively a never event situation or a difficulty, complication scenario, malpractice, negligence or something, and how can we manage this problem. It will be regarding the risk management team involvement, the incident reporting, the consultants referral, and so on. So this is simply the 10 stations of the OSCE exam of EBCOG. It was similar to the old-fashioned exam of MRCOG before 2016. The exam marking and passing criteria, each station will be scored between 0 and 2 points, 20 points, for a total points of all stations about 180 points. Okay, the pass mark for each station will be the median score of candidates evaluated as borderline. To pass the exam, candidates need to exceed the pass mark at least 75% of stations. So at least you have to pass 7 out of 10 stations. Okay. What I would like to say is the pass in each station is not that difficult. It's not that difficult because the evaluation will be at the level of borderline, not above standard candidate. This is a very reassuring sign that you can pass the station easily if you are just borderline, not above borderline. Okay, that's why we are assuming that this exam is considered easier in somehow than the regular RCOG new format. To be made in written exam, I mean, the exam will be held on November 2021. So if you would like to start preparing for the exam, it should be from now, as soon as possible. And in our course, we will offer, beside the regular training for all stations, we will offer 2 separate stations for EBCOG candidates to help them to understand the basic principles of their exam and how to deal with preparatory station, particularly because it's outside the scope of regular MRCOG exam right now. I would like strongly to thank you all for being with us today in mid-exam introduction session for OSCE preparations. Thank you name by name. Thank you so much for being with us today. And I hope all of you enjoyed our session, Dr. Pooja and me. And we will try to do our best to cover all important points and to help all of you to clear the exam from the first appeal and the first attempt. I know it's too late in your countries. Thank you so much again. And I'm really enjoyed every second in this session. And I will be very happy to receive your comments, your questions, your ideas, what you need actually from any course on our page of Mid-Exam Expert. And I will answer all your queries as much as I can. Thank you so much again, and hope all of you to have a great weekend. Yes, anybody would like to ask anything?
Hassam, yeah, I'm Jeet here. I have few queries about EBCOG-2 exam, though I have already booked that exam for 21st November.
Excellent.
And it is in Lisbon. If the pandemic will allow or will be resolved, then we will be able to go. Otherwise, it will be online basis. I just have the query, like in your course, because you are EBCOG. So in your course, you said there will be 2 separate stations for us. So it will be part of this course you are asking about.
No, actually, what I said is the core practice. For example, in 8 out of 10 stations in EBCOG, it will be as similar as the MRCOG. Okay.
Yeah.
So the 2 additional sessions will be exclusively for the preparatory station and how to deal with the clinical governor situations. Okay. Because the clinical governor situations are in AU guidelines somehow is different from the UK clinical governance principles. Okay, you got my point. That's why. But I will tell you something. I was the first, one of the first candidates attending the first EBCOG exam ever in 2016. Okay.
Okay.
I had MRCOG Part 3 exam at 3rd of November 2016, 5th of November, and my exam EBCOG was 17th of November in the same month. I studied for both exams the same study, okay? And I passed the both exams by the same study because they are synonymous to each other. But there are small differences, and these differences we will discuss in separate two sessions regarding the EBCOG principles. You got my point.
Okay. Yeah, I mean, you mean that there will be two different stations just for the EBCOG thing? That
Exactly.
whatever we need to understand about the European guideline regarding clinical governance or whatever, it has been different from us.
Yeah, and
from
at these sessions, I will give you the tricks of the exam. I will tell you one trick, for example, right now, just to just to show you a very important thing, how to understand the principles. Now, the AU had 37 countries. Okay, each country indeed has its own law principles. For example, in France, termination of pregnancy is allowable at any time during the 40 weeks of gestation. So for example, if the woman decided to terminate pregnancy for social reasons at 30 weeks, 35 weeks, it's allowable in France, which is completely forbidden in UK, for example, and in Germany. And you can see that all countries have its own law and principles, so that in EBCOG exam, you will never find any question regarding termination of pregnancy principles, because you will not never being able to remember the 37 different laws of different countries. You got my point. So they are concentrating on a very famous situations and very common situations in between all of these countries. So this is one of the tricks. We will concentrate as well on a very common conditions, and you will find them in exam in front of you directly. So it will be easy to manipulate and exclude different topics, a lot of topics from this exam as well.
Okay, fine, got it. And thank you so much for explaining. And you just now told that complex technical and teamwork skill, it is the structure of the one of the 7th point in the structure of exam. So like this means like there will be drills conducted, or like
we will
that?
Yeah, of course. We will try to, in the second session, we will try to show you the drills through videos. Okay, the ideal drills for example, breech delivery, instrumental forceps use through multiple videos, which are recommended by the European College and RCOG as well.
All right. Yeah, those prompt manual drills, are these the same ones, like prompt videos? They have those PPH and APH drills kind of a thing.
It's as same as those videos, but I will try to give you my comments regarding each video, okay, which will be helpful to be remembered inside the exam.
Yeah. Okay. So
thank you.
From 10th July, no. When from when this course will start?
Believe me, I don't know.
Okay.
the backup team informing me about the dates and everything, and I'm just open my presentation and start talking. So I don't know.
Okay. Thank you so much.
Thank you. Please keep contact with Mafia and with the team, the back team of the med exam, and all informations and all queries will be answered. Thank you all for being here today with me, and see you very soon in our course. All of you are so much welcome. Thank you. Bye-bye.
Thank you, Dr. Hassam, for your nice explanation.
Thank you, my dear. Bye-bye.